Good afternoon, everyone, and welcome to the readout reports for the breakout sessions. My name is Gayle Vaday, and I'm with the Department of Defense Congressionally Directed Medical Research Programs at the U.S. Army Medical Research and Development Command. We've had a great 2 days of wonderful talks covering a lot of information. And yesterday and today, we held some breakout sessions across 5 sectors. Really brought in some great discussions on some important topics on integrating sex and gender in research. So today we have 5 of us who are going to report out on our groups, and I'm going to begin with the federal sector discussions. Most of these will be from day 1, but I'm going to introduce or at least try to remember some of the items from today's discussion earlier at our breakout. So if we could go to the next slide. For those of you who attended the breakouts, you know we covered a lot of topics. The first was, for the federal group, was what barriers are presently in government that hinder integrating sex, gender, and other intersectionality considerations into research. And this is a big topic, a big question, and it took a while for us to get, really going on our discussions. But first, we talked about how the government's, simply encouraging diversity in clinical trial accrual really needs to go beyond that, and perhaps require investigators to recruit for such variables as gender. Other kinds of barriers that were brought up include concerns about privacy and related considerations. And then also considering the LGBTQ+ community as another important aspect in ensuring that the full spectrum of gender is included. Federal agencies do have inclusion of women and minority policies in clinical research, but as I recall, the LGBTQ community is not really captured in those, and so it really needs to be considered in policy going forward. Next slide, please. Continuing on now, what solutions currently exist in overcoming the barriers that were identified in our discussions? So the NIH and the DoD require a strategy for the inclusion of women and minorities in studies, and that's at the application level as well as the award level, with clinical studies requiring reporting on recruitment and accrual in their clinical research. This is a primary solution that first came to mind. And then finding a way to overcome socioeconomic barriers is also very critical. The group talked about how ensuring, for example, a working mother could reach the places where clinical studies are being conducted, making it sometimes difficult, especially geographically or whatever neighborhood she might live in, makes it quite difficult to get the not only the transportation, but perhaps the child care or the family care that's needed for the time away from home. Diverse groups of people are needed for studies, and so, as I mentioned, transportation, financial security, and other factors are not necessarily available in all areas or to all people. So outreach to underserved populations may not always be successful, despite this being more discussed more frequently. Women are disproportionately responsible for child care, as I mentioned. There's a desire to have women included in trials. However, that access needs to be considered maybe in the recruitment process as clinical trials and clinical studies are developed. At many government agencies, it's the program officers and the program managers who are at the front line of communicating with the research community, and they recognize the importance of promoting and facilitating inclusion in studies. So that interface with the researchers directly can incentivize inclusion. As you oversee, and I'm speaking to the program officer and program manager community, as you interact with awardees to bring this onto the forefront of those discussions, and conversely, possibly deny funding if inclusion is not adequately addressed. Next slide, please. So what solutions currently exist? This is a continuation of the previous slide. One challenge is that there are few natural history studies that are focused on women that have been conducted to better understand things like menstruation, menopause, puberty, the whole lifeline or life cycle of the female. And so without these natural history studies, it can be difficult to understand some of the dramatic sex differences that were discussed throughout the talks these past 2 days. The NIH does support some natural history studies in women, but they are less likely to be funded, unfortunately. The VA contributed some to this discussion and mentioned the Women's Health Research Agenda that has been in existence since 2004 and has supported numerous sex and gender disparity research activities. Next slide. So what solutions currently exist? Continuing on, there were some recent papers that were cited, and so there are some, as we look at the literature, there are different references that can be referred to as resources on this topic. It was suggested that when such papers are published, that the government engage with practice organizations that are responsible for screening measures to develop evidence-based standards, and that additional partners should be identified to help address the issues that make it difficult for women to serve as in clinical studies. Next slide. So what new solutions can be introduced by the government? It's hoped that there'll be an increase in databases identifying studies that consider gender intersectionality, promotion of self-identification of these studies, and journal publications requiring such identification. We hit on some of these topics also today during our discussions, not just in clinical studies, but also at the basic level with cell lines, repositories. Some of these very important resources don't have this critical information about sex and gender, which would really drive the success of such studies. One solution could be to have funders, in a harmonized way, increase emphasis on team-based science rather than individual PIs, to develop novel ways to reward and promote team-based science approaches to integrating sex, gender, and other intersectionality considerations into research. The increased reliance on different forms of machine learning was also brought up, and how it can be used for data analysis as an opportunity and a good starting point to re-examine the research environment in a more focused way on the inclusion of sex and gender when appropriate. Next slide, please. Now, the last question was to identify specific scientific, societal, and economic opportunities. Two opportunities were noted earlier in the form of machine learning and incentivizing team science, and another would be to facilitate and learn more effectively and to offer federal resources and partnerships to facilitate studies that include women and other underrepresented populations in clinical studies. That would be to overcome issues such as transportation, childcare, family care, other barriers that would keep women and such populations from participating. Next slide. Now, we have the big questions about women's health priorities. And so what was the #1 priority for women's health research? That was a tough one. I don't think we had many come to mind, but one was whole health for women. Today, someone also brought up healthy aging. And of note, women are discussed in terms of research and clinical practice, but the focus is on the reproductive system and capability. But women get a variety of diseases and conditions that are debilitating and affect their life course trajectory. Educating women and members of vulnerable populations about how different diseases specifically affect them is another priority, and that was brought up today as well. And that can come in the form of earlier education in younger women about how their life choices can affect their health later in life. Lessons learned from the All of Us research program should also be considered, and more effort needs to be placed on encouraging a broad spectrum of women to participate in research. And I believe we talked about not just in research as subjects, but also as researchers themselves. Next slide. Advocates and survivors should be included in the research enterprise as partners on the research teams to help remind researchers of the community's priorities. We know from many different efforts across different organizations that they are very important partners in bringing up things that scientists may not think about. So that is a very important aspect that we hope can be considered. Intimate partner violence and autoimmune conditions were noted as critical issues that warrant greater emphasis, and a stronger focus on maternal and child health disparities in the U.S. By all stakeholders is necessary to improve birth outcomes for those of socioeconomically disadvantaged groups. Next slide. So what kind of priorities should be placed after the pandemic? Cancer was noted as a priority, a continuous priority, given that this is a major women's health issue. For example, we may take lessons learned from what has happened so quickly with the Operation Warp Speed and development of vaccines and applying them to different cancers, women's cancers like breast cancer. Examining the clinical data on underserved populations would be helpful in setting priorities, and greater attention to social determinants of health data on health outcomes for women across their lifespan, as I touched on earlier. Mental health and emotional well-being needs to be a health priority for women's health, and with a greater emphasis on suicide prevention, violence, and gender-based violence. Next slide. And then we had the tough job of ranking a priority to advance the health of women. So it was suggested that increasing the number of women, as I mentioned, in the biomedical workforce and rewarding team science will help make women's health a priority because more women will be involved in the biomedical research ecosystem. Next slide. So some participants indicated that addressing the burden of low wealth for women and equal pay was also a priority area of focus. Women are paid less, but they live longer. Getting treatments to people who need them the most was also noted as a priority, as we may have gained in the area of disease screening, but once we identify health issues, it's getting the treatments and the follow-up to those people who need it the most needs to remain a priority. And finally, I want to point out that we also talked about building partnerships with the pharmaceutical industry as a priority for improving access to treatments. So it was a lot discussed, but certainly a lot of points you may see in the coming slides. But I want to thank you all for the opportunity to participate, and I'm now going to pass this on to Mila Becker as the next speaker. Thank you.
Thank you very much. My name is Mila Becker. I'm the Chief Policy Officer at the Endocrine Society, and I had the pleasure of facilitating or co-facilitating the professional, scientific, and medical and advocacy organization breakout session, along with my colleague Jemima Philippe from the AAAS. So, to go through the findings or the high points of our discussion, I also will start with the question of what barriers our group saw in scientific, medical societies, and advocacy organizations that hinder our ability to integrate race and gender and other intersectionality considerations. And I think we agree that it starts with the baggage our members bring. So to explain that, our organizations are made up of members, and some of them may not have had the benefit from their experiences of understanding how to incorporate sex and gender, or how to report on sex and gender and sex differences, or they did not ever feel that they were tested in this area and or thought it was happening naturally without them. Secondly, we saw one barrier being that some organizations may not recognize the role that they could play in affecting change in this area. And that organizations really need to acknowledge their role and act more deliberately about intersectionality. The good news here is that by virtue of this symposium, I think many of us have learned or confirmed that medical societies, scientific organizations, and advocacy groups do have that ability and can work on that individually and collaboratively. So that's good news. Thirdly, we discussed that members of societies who may have the strongest reaction to this issue may not necessarily be the decision makers at their organizations, which could cause them to hesitate to bring it up. Some in our groups even apologize for saying, you know, I'm the crazy one who thinks about this. And so what we said is that that's a barrier, and we need to know that this is a legitimate issue that anyone can bring up and bring to the attention of their leadership. Next slide, please. We also discussed solutions here, and we decided that the way our organizations are structured today, so in nonprofit groups, you tend to see a publication and journals department. You see an advocacy arm. You see an education programming section. And by virtue of this kind of structure, organizations can take multiple steps to integrate sex, gender, and intersectionality into the biomedical research enterprise. We talked specifically about how journals can lead the way in developing policies that encourage reviewers and authors to consider SABV and report on sex differences. We talked about how societies can train reviewers about what should be reported, integrate guidelines that are meaningful, make sure reviewers are held accountable, and challenge authors to think about their research design. The Endocrine Society, for example, has created such policies for its journals and have found them to be incredibly successful, because just asking in the submission process if gender was considered, if it is part of the research design, has made our authors think about that and incorporate this more and more. We talked about education departments developing training resources to educate the members of the organization, but also to develop summits and convene members as well as people outside their own organizations to think about action steps. And it goes without saying that advocacy departments can advocate for policies and research funding. Next slide, please. So in talking about what new solutions we can bring to the table, we discussed that one thing would be the carrot approach. In other words, discoveries that have identified sex differences or ways that SABV policy has affected research thinking should be celebrated and rewarded by our organizations. The profiles of investigators who have used these kinds of policies successfully should be raised. And that can be done through recognition at annual meetings or even monetary awards. We also discussed that journals should celebrate discoveries that identified sex differences and how SABV policy has played a role, and highlight that over and over again so it becomes part of everybody's thinking. We also discussed the visibility of the Office of Research on Women's Health should be increased among society members and science. We talked about how organizations like ours can highlight the office and can advocate for implementation of the office's policies throughout NIH, across NIH, across federal agencies, and even in the private sector. Next slide, please. In terms of identifying an opportunity that the integration of sex and gender would have in societies or advocacy organizations, I think the overarching discussion point that we had is that we need to be cognizant of and focus on the fact that an improved understanding of SABV helps achieve broader aims in medicine and health. And integration of sex and gender has a significant societal impact. It can lead to more effective medications, fewer adverse events, better health care. And in other words, it needs to be part of everything that we do, not its own island in a sea of different issues that our societies work on. One example of how this could be applied is that looking at how SABV affects many health endpoints and will improve the understanding of opportunities associated with complex issues such as environmental exposures, for instance. Societies can advocate in a more targeted and more effective way with clear linkages between exposures and health effects, particularly if we can note how certain groups are affected disproportionately. Improved understanding also can help with identifying champions. Next slide. In terms of women's health priorities, we really had a very vibrant discussion on this both days in our breakout sessions. And while we struggled initially talking about all these different issues within women's health, or to highlight women, we did not want to pit one disease against another. Breast cancer is really important, but so are other cancers. Heart disease is really important, but so is PCOS. And so what I think our group decided on, or where our consensus ended up, was that the number one priority is sex differences research and translating those findings into clinical care. Another critical issue that emerged is that women's health should be considered in the context of better health for everyone. If women's health had already received equal consideration, we would see less gaps, but that isn't the case. And the fact that women and women's health may have been deprioritized in the past should be identified and addressed. But we need to shift to a human health perspective to address the marginalization of women, and also look beyond women's health to areas including workforce development, access to participation, and the ability for women to advance in research careers. Next slide, please. Thank you. So after the pandemic, what we talked about was that if there is a silver lining of COVID, it is that it has highlighted the importance of SABV, and that the society at large has begun to understand that men and women, or males and females, were affected differently by the virus. Men may have a higher mortality rate. Women may be more likely to become the long haulers. Males and females may have different reactions to the virus. And so this has become very tangible to our society, and that we should use these learnings to catalyze upon the issue of SABV in everything that we do from this point forward, and take the learnings that we have from COVID and apply it in other scenarios as well. Next slide, please. So, in talking about criteria that should be considered when prioritizing topics to focus on for women's health, we talked about a lot of things. We talked about cultural status. We talked about gender roles. We talked about matriarchal societies. But again, we came back to the issue that is that we need to look at this as part of human health. And that if scientists want to include women in research, they must make research accessible and a positive experience for women who are considering careers in the research enterprise. Next slide. So when we got to the ranking issue, ironically, each participant prioritized these criteria in a different order and considered the priorities through the different lens of their organization and their organization members. People emphasize different things, such as which issues would be easiest to educate stakeholders on, or which have the largest impact on long-standing problems. So each lens really yielded different results, and no one was wrong. I think that was something that we concluded because all of these things are clearly important. Next slide. But again, I want to emphasize that this issue of not being able to rank consistently probably demonstrates that another hurdle in our community. And so what we can't, it's not that we can't agree on priorities. I think it's that we haven't figured out a common lens to look at this through, because all options are important. So bleeding into today's discussion about collaboration and partnering across sectors, again, the themes that came out is that we need to think more about partnering. We don't do this naturally. We need to find ways to share resources with each other. And we need to find a rallying cry that we all can get behind. And that may in fact be SABV and support of the Office of Research on Women's Health. So those would be things that we all share. They may not be the number one issue of each organization, but they are things that we can share, we can work on together, we can advance, and we can break through the hurdles together. Thank you.
Hi, I don't know if you can hear me. We had a little trouble there unmuting me and bringing me up on camera. After listening to the previous two presentations, there is so much overlap, included in the industry and business and private funders groups that we had over the last 2 days. My name is Sara Demy, and I am the founder and CEO of an organization called Demy-Colton. And Demy-Colton organizes large events and some smaller events for people, participants, innovators in the biopharmaceutical space, digital medicine, healthcare. So I come at this from a quite a different point of view, and I think so did our audience, because we had a number of people that were involved in business. So you will hear quite a bit of overlap, maybe not stated in the same way, but there's a lot of overlap between my presentation and the previous two. So the very first one on this slide is, what are the barriers for industry and business and private funders that hinder integrating sex, gender, and other intersectionality considerations? And one topic I will point out is that kept coming up throughout the course of our discussion was women who are pitching for business or investment are always typically pitching to men. Typically, the venture capital community has been dominated by men. That has changed in the last few years. There are a number of new organizations that are coming into the fold that are supporting and investing in women's companies that focus on women's health and women's issues, which is really huge, and we hope to see many more of them, including female partners in their own organizations. Another issue is that there's a perception that there is limited commercialization opportunity or markets for products that might be brought forth that address women's needs and women's issues. And I think there have been a number of studies that have actually disproved that, but that is not readily understood in the business community. So the bottom point, the last point that I'll make here is that there is a lack of will or refusal to respond to well-documented disparities in women's health, such as high levels of asthma or in racial or ethnic minority communities. And I think that is an issue that you'll hear over and over again as we go on or as we look at the other slides. So can we go to the next slide, please? So on this slide, we were speaking about what solutions currently existed to overcome barriers identified in integrating sex, gender, et cetera, and biomedical research, but we come at it from the business point of view. And the group really would like to see more access to investment that could be focused on transformative issues in women's health. And the group also believed that there should be regulations for both research as well as industry that would include sex and gender in biomedical research. And further on, you'll see that there's also a desire by the group that joined us yesterday to see women appointed to top positions, both in government and research, as well as in industry. And one of the issues that we brought up is that when you go to Europe, there's a strong requirement that women need to be a part of the boards of directors. And already we're seeing that have an impact on the way companies are run. And we think the same would happen here in the US. Next slide, please. So what barriers currently exist and how do we overcome them? Educate industry about the market potential for women's health products. I think that came out very, very clearly yesterday in our discussion. Another point on this slide, and I think this may be misplaced, but it's here anyway. One of our participants brought up the fact that, like one of our previous speakers, that women during the pandemic really lacked access to getting healthcare, getting their needed medications and everything. And one of our business people that was in our group suggested that drones be used or employed in cooperation with government and academia to bring needed medications, therapies to women in areas that don't have access, as well as to people in communities that don't have access to pharmacies, both rural and urban, which I think is a really unique approach to getting therapies to people. So can we move on to the next slide, please? So in this topic, we were discussing what solutions can be introduced across industry and business and private funders that would promote integration of sex, gender, intersectionality into biomedical research enterprise. And I think our very first point is that there should be sex and gender requirements to receive private sector funding. That I heard in the last two presentations, so I think that we are very much in agreement with that. And that all people, all races, ethnicities, ages, should be included in research. We also discussed the difficulty of including women, in particular during the COVID time, in clinical research. Accessibility is a big challenge. Women are healthcare providers. Women take care of children at home. Women often don't have the means to go to a facility. So there are clinical research organizations that are rethinking how they do clinical research by being very patient and participant focused, by going to them and making participation in clinical trials as easy as possible in order to break down the barriers and to keep people that have participated in clinical trials going in trials, especially when you have a major interruption such as COVID. We can go on to the next slide, please. So here we discussed scientific, societal, or economic opportunities that the integration of sex and gender would have for industry and private funders. The major point that our group discussed is the very first one here, that studies of sex and gender are critical for the advancement of women in health research products, and they present a huge commercial opportunity. I think the value of the women's healthcare market is not widely discussed or understood. It's been somewhat ignored, you know, in the past, but it's a vast market, and there are organizations that have been conducting studies. I think one of our participants in the steering committee actually commissioned a study that addressed this as well. It's a valuable market that individuals and companies need to pay attention to. We also talked about the fact that autoimmune and endocrine diseases have a major impact on women's health, and present major research investment opportunities. And here again, we spoke about improving pharmaceutical delivery to hard-to-reach communities that do not have easy access. We really held on to the drone concept of getting medications and therapies to people that were in need. And in this particular slide, if we can move on again. The number one priority for women's health, according to our group, is cardiovascular disease, depression, and Alzheimer's. And we underline that with saying that the greatest priority should really be focused on the diseases that cause the most disability in women, and certainly the top three do. We also spent a bit of time talking about maternal mortality, not only here in the U.S., but globally. In the U.S., we do a very poor job of taking care of women who are giving birth and who have given birth. I think we rank well at the bottom level, or the bottom ranking of all the developed countries in maternal mortality and death of child. And that is something that really needs to be addressed. We also spent a bit of time speaking about the development of sex-dependent and sex-specific therapeutics and precision medicine. We didn't go into the details of exactly what that could include, but we did speak about that. So if you can go to the next slide, please. So after the pandemic, this is again the same questions that were answered by my other colleagues, and the number one issue that came up was the lack of child care accessibility and support for caretakers, which really seriously affect women's ability to participate in clinical trials. One of our participants conducts her study specifically with women, and she had to end her study during COVID because the women could no longer participate, and then the study becomes somewhat invalid. So I think it's there's been a lack of attention, and I think everybody in our group would agree, to the needs of women and providing them with enough support to be fully participatory in everything, in the economics of what we do. So the other issue is that we think that the pandemic accelerated the use of technology, and I think that goes, that's across all levels of healthcare for everybody. And women who could not access broadband or didn't have access to those networks were left behind during the pandemic. Okay, if we can go to the last slide, I think, or there are two of them. So our participants noted that the lack of funding to investigate certain topics has impeded the advancement of research in many areas. And one of the examples was that both the heart and the uterus respond to certain electrical impulses, but there have been no studies to focus in on that and what that means and how it would impact health. And another one of the top priorities affecting women's health was the environment. And I think this was mentioned by our very first speaker. And you can read here the various issues that this addresses, including sanitation, water, insects, air pollution, in particular during pregnancy, and the high exposure of women in minority communities to chemicals and pollutants, etc., that will affect their children. If we can go on to the next slide. So what criteria should be considered when prioritizing topics that focus on women's health research? Digital health is an area that has certainly made it very easy for women to access care. I think our group agreed with that. And if you go down to the bottom, I did not calculate the numbers of people that chose that ranked global burden of health or domestic burden of disease in order of priority. We'll have to do that after this is over. If we can go on to the last slide. So here you can see that although reproductive medicine is critical, industry must understand that women's health and sex differences are not limited to reproductive health. In other words, we need to focus beyond that. Sorry, excuse me. And we think that there is a stigma that with women's health that continues to prevent full participation and investment and research in women's health and sex and gender differences. And, again, it's largely attributable to the fact that in research as well as in funding, those organizations are largely male-run and male-dominated. I think that is changing, which is good. And COVID-19 pandemic revealed substantial disparities in systemic support for women And I think that is it. With that is our last slide. Did we go on to the last slide? I think, yes, we did. Okay, it's my turn to turn it over to our next speaker. And I thank you all. Thank you all very much for listening.
I'm the type of person that talks. Oh, well, thank you for unmuting me. I'm the type of person that talks and thinks in bullets. So I do have slides here, but I'm not going to read them because I did my own little editing. My name is Jan Werbinski. I'm president of the American Medical Association, and I had the honor of facilitating the section on academic and research institutions with Dr. Elena Rios, who couldn't be here today or tonight. So we had a group, a really diverse group. We had a man from the Endocrine Society, and we had a woman who lives in Uruguay, who had her daughter on her lap for some of the sessions. So I thought it was very interesting. The first question that we pondered was, as the other presenters have said, barriers that hinder integration of sex and gender. And those were caregiving responsibilities of both the subjects and the researchers, if the researchers are women usually, transportation difficulties, hours available to participate in either setting up the research or being the subject. Men in male-dominated fields seem to fail to recognize the challenges that women face. And in preclinical research, there's a lack of study of female animals, and the sex of stem cell studies are often not reported. So it's hard to make any suggestions if we aren't even including female animals. Anticoagulation research was something that was mentioned, that there's standards to capturing the amount of menstrual bleeding are insufficient, and so it's mostly men who are studied in the anticoagulation research because it's easier to default to them. And we need an improved definition for abnormal menstrual bleeding. Today, we added a few barriers, siloed funding. The funding comes through the department, and it's hard to collaborate and share that funding. One person said there's little space to explore new fields because there's just a certain amount that's taught. We talked a lot about education in this area. There are communication barriers because not everyone has the same definition for certain words like sex and gender. And there's low education on the definition of sex and gender. So we talked a lot about education. That's a barrier. We can go to the next slide. Currently existing solutions. We talk about education. We really hit education a lot. Education of the researchers on the impact of sex differences. Education of the research subjects on the difference between sex and gender. An NIH call for consideration of sex in animal research. So we thought that was a plus, that it's an existing solution that the NIH is asking that female animals be included in the research. And social media and journalists can inform the public on the need to include a variety of sex, gender, and intersectional subjects to studies. So we might get more people to volunteer that way. Another existing solution is mentors for women researchers, collaboration between investigators. One woman who has participated in the Birch program applauded its work, and she said it was a wonderful program. So that's an existing solution. And then the study of sex as a biological variable and gender as a biological variable adds rigor and responsibility to our studies. Next slide. The next slide was talking about new solutions. You know, I just talked about this slide, so we need to go to the next one. Okay, what new solutions can be introduced to the academic and research institutions that will promote integration of sex, gender, and intersectionality? So new solutions we talked about were, this is the best one, I think, for IRBs to list inclusion of differences as an ethical consideration. And one person mentioned that some IRB boards are electronic, so we could fit that ethics question right into the IRB recommendations. More journal editors which embrace the Sager guidelines, and they can require researchers that before they accept a research paper, they can require researchers to add to their limitations in their paper a section that not only how many of the opposite sex were included, but why the data was not disaggregated. Cross-field symposia on sex and gender differences. Again, we talked about education. In-service peer-to-peer training and mentoring of junior researchers. And another person said, not only mentoring the junior researchers, but junior researchers often have better, more inclusive ideas about sex and gender and intersectionality because they've come through school learning those things. So the junior researchers might mentor the senior researchers in those areas. Delegate someone at the institutional research office to advocate, promote, and guide inclusion of sex and gender research. Hold courses on sex differences for people getting higher degrees like a master's and a PhD. And additional funding specifically targeted to sex and gender research and education. And today we expanded the new solutions, and we talked about, again, about the IRB, but we talked about trickle-down communication and education. And we trickled it all the way down to high school. So the NIH has a lot of information, but it needs to trickle down to not only higher degree researchers, but undergrads and even high school biology, so that people just automatically think about sex and gender as something we need to study. Courses on gender studies in grad schools and community engagement. We mentioned some of the research that's done in beauty shops and barber shops, because especially for African American women, they're in the beauty shop for sometimes 4 or 5 hours having all the braiding done in their hair and different things. So we thought it would be a nice place to bring some education and maybe get some people to participate in research. Okay, next slide. Okay, this one is identify a specific scientific, societal, or economic opportunity. And we talked about more opportunities for women and minorities to author research because they ask different and more targeted questions. Convene meetings in the institution's diversity office to educate and discuss implicit bias. More research on methodology courses and identifying ideas for the future. And this could be modified to fit NIH grant recommendations. And leveraging the existing NIH diversity supplements. And this is a big one that came up today, what we could do. The Collaborative Institutional Training Initiative, the CITI, that everybody who's a faculty at most medical schools have to take, we could add ethics training into that and talk about sex and gender differences and intersectionality and why those are important. We talked about the Office of Women's Health Research modules and their primer, which are, I've taken some of them myself, and peer-reviewed some of them. They were really excellent, and the primer actually tells people how to study sex and gender differences. Next slide. Women's health priorities. Currently, what is the #1 priority for women's health research? And on the first day, we decided cardiovascular disease was the most important because more women die of that, especially African American women, than anything else. And then we thought, of course, we couldn't just say one. We talked about drug development and monitoring, looking for adverse effects, especially in women, because we know that many drugs have more adverse effects in women than men. And we talked about drug development because it spans all specialties. So it's one thing that isn't necessarily in a silo. And then the proteomic profile of body systems informs many other areas of drug therapy. And today we talked about other priorities. And today we talked mostly about education. So we talked about early sensitivity to sex as a biological variable and gender as a biological variable. And we talk about understudied diseases in women. I mean, we're assuming that the OBGyn community studies gynecologic diseases, but we mentioned, and this came up in some of the panel discussions too, endometriosis and fibroids are not well studied. They're treated with surgery, and that's it. And we had a panelist today talking about different ways to diagnose endometriosis besides surgery. So we really think we need to put a lot of effort into women's diseases. And cardiovascular disease came up today also as a primary women's health priority. Next slide. Okay, after the pandemic, should the priority shift from what we just said, or do you feel there should be another priority? So yesterday we talked about this, and we said focus on differences in response to medications and vaccines, because we're still going to have to worry about pandemics even after this pandemic is over. A major plan that is generalizable to a pandemic regardless of the disease. Researchers need adequate accommodations and support to perform their work, especially women who ask diverse questions, and research on women should not be restricted to women researchers. So we were talking about more effort put into the researchers' ability to do their research. And then the pandemic has differentially affected the careers of women with young children, because those are the people who had to drop out of the workforce and stop their research early. Men tended to be more able to continue their research during the pandemic. So we need something to boost those young women back into their careers, because their careers are being really affected by this pandemic. So we said that academic institutions should focus on measuring the broader societal impacts and relevance of research to women and marginalized groups when determining the return on investment. We talked a little bit today about sustainable approaches for pharma and device companies for engagement with public approaches. So we're talking about a partnership between researchers and pharma and device manufacturers. Okay, we're almost done, guys. Next slide. What criteria should be considered when prioritizing topics to focus on for women's health? And we said the magnitude and degree of change should be considered. The population, not just of the researchers, but of the subjects, should be addressed. And should there be a legislative effort? We talked about the pay difference between men and women, even in the research area. And so we thought, well, maybe there should be pay transparency. That's probably the only way that we're going to ever know that men and women are paid the same. Next slide. The next slide was the ranking that every group was given to do, and I actually put mine in the order of our votes. The number 1 in our group was domestic burden of disease. Number 2 was global burden of disease, global. 3 was the largest return on investment. 4 was less funded areas and topics. And 5 was the greatest potential for advances using technology. And I think the last slide. The last slide is our summary, key observations, and recommendations. Number 1, sex and gender biases affect both researchers and the quality of the research they perform and the research subjects. Number 2, cultural changes and educational efforts are needed to recognize and address the changes that women and minorities face in their careers. And number 3, additional metrics, rubrics with set criteria for hiring are needed to ensure that diverse voices are included within the research community. So that is the end of my presentation, and thank you for asking me to do this. I thought it was fun. And I don't know who's next. But I'm going to turn off my camera.
Hello. Good evening. I'm Nathalie. I'm a Chief Life Sciences Editor at Nature Communication. It was a pleasure to facilitate the session from publishers and journals together with Carla Shepard-Robinger, who is Vice President of the Marianne Liebert Incorporation and Executive Director for the Rosalind Franklin Society. A lot of the things we discussed were already covered by people from the other breakout sessions, so I'll try to sort of not repeat some of those things and perhaps bring additional thoughts to the topics. So on the first day, we focused a lot on looking at not necessarily the research per se, but the researchers, the reviewers, the editors, the authors, and who they are, and are they able by their demographics to really take into account sex and gender and intersectionality considerations. And so a lot of us felt that the data on that the research workforce, so to speak, as seen in the publishing landscape on diversity and equity, were currently lacking. We discussed that some algorithms exist to get access to some demographic trends. However, those do have some issues as well, and they are not very precise nor necessarily scientifically robust sometimes. So another possibility we thought could be that journals could be asking people to identify themselves based on sex and gender, race and ethnicity, but that may require the ability to define globally categories. And we evoked that for gender through efforts like gender innovation. I was talking about in the first day, we can do this now, but perhaps for looking at race and ethnicity, especially at the global level, that's much more complicated. So that seems to be a barrier to be able to look at that. We also discussed that there could be implicit bias that hinder the implementation of sex and gender equity in research. That is linked to the fact that we don't have that data, but also the bias may exist when we have that data, and that possibly existing biases are exacerbated by lack of ethnic and gender diversity in position of power within publication and the research field. So we also found another barrier that was discussed quite a lot regarding how to report sex and gender data. and it was felt that at the moment, it seems that the publication formats we have perhaps don't have enough opportunity or space to allow those considerations to be discussed and presented correctly because they have strict word limitations, for example. Next slide. And so we first looked at, looking at through our publishers and journal lens at the solution that currently exists for publishers and journals that can help to overcome some of those barriers and issues. And so regarding, the implicit bias, we discussed that perhaps sensitivity training may help with those problems, and so that the training should happen at all levels of the research workforce, researchers, editors, reviewers. And then we also discussed another thing that already exists in for some publication is to use what is referred to as sex and gender champion in the review process. So, for example, if a paper is submitted that appears good but does not really address sex and gender reporting sufficiently, perhaps some journal editors are already doing this, and they can assign such a champion who will work with the authors to help them revise the paper to better address those topics. Another thing we discuss quite a lot is that there are already existing frameworks for the reporting, and so journals should really have a strong effort to ask authors to be transparent about sex and gender and intersectionality using those existing checklists, such as the Sager guideline that some Bible presented on the first day, but also the fact that some of the clinical related checklists, such as CONSORT and PRISMA, already have an extension looking at equity issues. And given the framework exists, it seems a low-hanging fruit to enforce their use more. Next slide. And so we also try to think of new solutions that we could introduce as publisher and journal. Some of them are easy to introduce, possibly. Others will require a lot of more thinking. And definitely, we all felt that coordinations between publishers and journal will be a good thing. So among the things that we think could be easily introduced as the fact that, we could ask manuscript reviewers to ensure that they have looked at whether or not authors have included an analysis of sex and gender and other intersectionality matters. Publishers and journals just have to be very straightforward asking those questions. And another thing which we discussed, which is linked to that idea of lacking space, it would seem that one solution would be to just expanding word count limitation for publication. However, many journals are already online, so that word count limitation doesn't really exist anymore for many of them. And perhaps more than extending the word count, what is needed is a framework defined and adopted by all publishers and journals to ensure that a figure or a table or a subsection is always included in each paper. And even if that table is saying that the authors didn't consider sex and gender when they did their research, and so perhaps next time they may do it. Another thing we discussed is that perhaps to sort of really shine a light on the existing bias, some trials could be conducted to reveal those bias. And trials that could be done using actors, for example, and actors and some electronic methods, and involve physicians into those trials, and so that they will realize that they have some bias that they didn't know. Next slide, please. Among the other solutions we discuss are the idea of how can we expand the reviewer pool to include, people who are really aware of the issues under study, and so are there ways that journals And publisher can involve at some point in the review process members of advocacy group or patient-centric groups, and that may help in improving representation. We also discuss the possibility, perhaps not applicable for all research topics, but under some conditions, journals and publishers could think of asking authors to include an author belonging to the community under study, and this could result in fewer omissions of concern specific to that group. There is also the hope among the editors who were present that if journals which are considering quote-unquote legitimate really push forward the agenda of including sex and gender intersectionality in the reporting, then that will sort of provide more visibility to those issues. Other journals may who are not so stringent in their reporting may not be considered as a good place to publish, so to speak. And so we discussed the fact that there are many more predatory journals around and how to address that. Next slide, please. And so I guess when we looked at an opportunity where publishers and journals can really help in moving the agenda forward, we sort of went back to our first discussion point, which was looking at the data. And so we thought that promoting women and the represented group to senior positions in professional journals should be continued to address that. And overall, in the research landscape, achieving greater diversity in powerful professional positions can alleviate existing bias, and hopefully that will affect the whole publication process and existing body of scientific literature. Next slide, please. And we looked at women health priorities as well, and again, with our data-driven approach, I guess, we thought that currently, the highest priority is collecting sufficient sex and gender data to relate to COVID-19 and general health. And after the pandemic, we thought that it would be important to focus on social aspects of women and intersectionality in health research, and ensure that this is integrated at all levels. And we also thought that given how successful partnership with industry has been, this should be built upon as a success and continued for the topics found of interest to study. Next slide, please. Oh, I apologize. I'm French and I have to report on women health research in the United States. We discussed, the priority topics to focus for women health research, and I guess what the editors present felt that it should use the health metrics in the United States related to gender, sex, and compare them to other countries. There are areas where the country is doing quite well, and we should strive to remain to lead. And in areas where there is an effort to be made, then perhaps compare to countries where things are doing better and see if things can be improved upon that. And so we also think that looking at the data around all those matters will help consider the nature of gender research in multiple disciplines and contexts. And again, we sort of really discussed quite a lot, I think, about the social determinants of health and how we have to integrate this. And I think that is valid not only for most of the things anyway, for the United States, but also globally. Next slide, please. And so I think we spent a lot of time discussing all the other matters, and we ran out of time to do the ranking of those the priorities. However, there was sort of a dual effect we were discussing quite a lot here, which is that perhaps focusing first on the domestic burden of disease and to really address the issues which are happening in one's countries will be quite important, and then use that as a platform to look at the global burden of disease as well, and how do we compare to one another. I guess this is coming back to what I just said on the previous slide. The other topics we found were all important, but we were not able to rank them. Next slide, please. Oh, I'm done. Okay. So, yes, I don't think I have any other slides. Thank you.
Well, we have certainly heard some wonderful, exciting, and stimulating recommendations and responses to the questions that were posed within the breakout groups, as well as during the fantastic panel discussions that have been held over these 2 days. We're already over time, so I'm going to be very brief in my closing remarks, and there's certainly no way I could summarize in 5 minutes or even 15 minutes or an hour the wonderful suggestions and comments regarding the science and regarding advocacy and regarding just all about women's health and women's careers that we have heard expressed over the last 2 days. I do want to make just a couple of comments, however, in closing, so I won't completely ignore what I was supposed to be doing. First of all, I'm delighted that almost all of you ended up with what really is the central mission of the office, and that is to think of women's health research as addressing the entire woman, the whole woman, across the lifespan. In fact, we originally talked about it as beginning in the intrauterine environment all the way through childhood, adolescence, the reproductive years, the post-reproductive years, the premenopausal, the postmenopausal years, and the frail elderly. And so hearing discussion about giving more focus to childhood as well as more focus to the elderly is certainly important, but we also recognize that if we're going to really be able to prevent some of the conditions of elderly ages, we really need to focus on what we do in terms of behavioral aspects in the early ages. So I'm really pleased that almost all of you came through with that. I just have some concerns about the thought about prioritizing diseases, because when we first started, as I looked at those that you were considering, those were really, I think the office first started, our first priorities were 8 or 9 disease topics: autoimmunity, heart disease, endometriosis, uterine fibroids, depression, etc. And over the years, as you have seen, we went away from focusing on specific diseases because the office has such a broad constituency. There are those who feel there needs to be more research on the conditions that lead to greater morbidity among women or more disability, those who feel there ought to be more emphasis on the conditions that lead to a greater mortality among women. There are those who feel that conditions that affect them or their communities but may not be the most prevalent really deserve research. And so that is why we had tended to move towards thinking about more generalized topics rather than specific diseases. Many of you in your working groups and in the breakout groups came to some of those same conclusions. And I think that will be wise, because the office really does have to respond to a variety of constituents and a variety of advocates, and as well as a diversity of the scientific and research community. And to rank one versus another, you don't want that competition. Although if funding decisions are made, there has to be some priority there. And I'm glad Dr. Clayton and the members of the office are going to have to deal with that. I heard over and over about partnerships, transformative collaborations. I think that's wonderful, and that's certainly what women's health research needs. I love the fact that ORWH is still in the forefront, but is collaborating with not only other portions of the federal government, but also with industry, also with advocacy groups, also with individuals, with academia, with all of the different groups that were represented in these discussions, and that is important. One concern I have is that certainly I think partnerships are extremely important, and working together will give us the strength that we need, and that's the synergy from all the different components of the women's health research and women's health research career communities working together can achieve. But I did note that interdisciplinary was not mentioned once. If it was mentioned once, I must have been on a bio break because I didn't hear it. And that was a major priority for this office from about the year 2000 to 2011. And perhaps that is no longer considered a priority, but I think it does fold into the concept of of collaborative work and combining synergies across specialties. And it did bring into our community of women's health researchers many who had not really thought of themselves as women's health researchers and became some of our major supporters of initiatives of the office and dealing with women's health, bringing in more of the institutes to support and collaborate with the office because they then saw through this interdisciplinary approach a role for them and became some of our greatest sponsors. But perhaps things change and you've moved on into other areas, but I just have to mention that because I thought that was one of our greatest developments. So we'll move on into the new areas. Certainly looking at the role of supporting this research, and I like the fact that you not only came with several suggestions about providing support for the office's funding, but also with private funding and private philanthropy, and especially women's philanthropy, giving attention to women's health research and conditions that affect women as much, if not more than men, with women paying attention and giving attention and bringing attention to that. And again, that gets to sort of, again, a partnership and a collaborative responsibility, which I was very pleased about. Certainly the office cannot ask for more funding. It cannot do that. But our major advances in this office historically for funding for its programs have been from advocates who've made appeals to members of Congress about areas they wish to see funded and funded within the office and not disease specific, because disease specific funding tends to go to the institutes, which are all based on diseases. And that's just something, since I'm retired, that I can say that I could not have said while I was still in the office, but just to make you aware of that. I think in terms of COVID and thinking of, and why it may be important to have more generalized priorities. If you take COVID, which has been referred to many times, if you heard Dr. Fauci last night talking about, the differences, some of the sex differences, and he talked about how they're now investigating some of the same autoimmune principles that have been investigated for many years. That is, why do we see many of the autoimmune diseases affect women more harshly than they do men? And perhaps that is one of the mechanisms that's playing into what we're experiencing with COVID. But in addition, knowing that mental health is going to be a major concern, not just for women, but for everyone, but with our particular concern about women who have been confined to the homes, who've been carrying extra stresses, dealing with the extra stresses, perhaps related to their employment or their research or their job opportunities. More demands for looking at mental health, looking at what we've referred to in the past as work-life balance has all been changed now with women with the major caregiving structure and having to deal with most of the homeschooling and taking care of families at home, and recognizing again, I'll add one other concept that perhaps may be something positive out of this, that certainly more attention is now being given to the fact that we could lose more women from the workforce, lose more women from academia, lose more women from labs and from research because of the lack of child care facilities, and perhaps even with the government and paying attention to this, that something can be done to help relieve some of those stresses for women. But recognizing women as caregivers, I think finally is hitting the consciousness of almost everyone. And then, of course, looking at the role of technology, and that has been brought to the forefront during this pandemic. So just using COVID as one example of something that can bring about a whole mixture of different priorities that can be developed out of one context or one situation or one pandemic. But really getting back to just what I've heard, it's been very encouraging. I've just been thrilled at hearing the concepts and the thought that each of you has given to the topic that you presented. The fact that we do need that collaboration, we do need that partnership, we need to involve men, but we certainly need to do more about increasing women in leadership positions, not only in the lab, but in other entities with which we interact, in industry, in government, in academia, because if women are in leadership roles, hopefully recognizing they will give more thought to or be more appreciative of the need to look at sex differences and women's health issues, that being in decision-making positions, they will help to overcome some of these barriers that have existed from day one that we hear that may have been lessened to some degree, but still need a lot of work. Certainly, I was pleased that there is lots of attention being given to SABV and to intersectionality. And that was evident throughout all the presentations and throughout all the discussions. And I was delighted about that, because women's health should really be addressing not just those reproductive issues of women, but also those conditions that affect both males and females, both in the animal model as well as in humans, and recognizing when there are differences, why those differences exist, and also recognizing that intersectionality and all of the concepts that fit under intersectionality should have been and should continue to be extremely important. I could say more, but I couldn't begin to summarize all the wonderful comments. I just was just thrilled with the concepts. And Dr. Clayton, I'm so delighted with the work that you and the ORWA staff have done and forward in moving towards strategic planning for the future. And I commend you for what you've done. And I offer you a little bit of sympathy and support for how you're going to act and be able to incorporate all these wonderful ideas and suggestions that have come forward during this Tuesday symposium. And lastly, I have to thank you for putting my name with this symposium. I've been really touched to hear the comments and to thank you for recognizing me in that way, when in fact it is you and the members of the staff of the office and others at NIH and your colleagues and your advocates and your friends who are doing the work today. And the last comment I want to make is to remind you of something that Jamie White reminded me this morning, and that is there have been some wonderful presentations. You may have missed some, but if you are interested, that all the presentations will be on demand in the LabRoots platform for up to a year. So anyone who is registered for this symposium can go on to the on-demand option for past panels and talks and be able to see them again. And I went back and actually looked at a few that I had missed during the breaks today, and they are there. So with that, I think we're bringing to a close what has been a symposium that so many on the steering committee worked so hard to develop. Jamie, you were just marvelous in pulling all of us together and coordinating the wealth of information, the breadth of thoughts, and pulling it all together. And Dr. Clayton, thank you for making this happen. I look forward to doing what I can to support any further efforts in any way that I can, because I think we're all invested in women's health research, whatever it represents, and in promoting the careers of women in leadership positions, and if not leadership, just being successful in doing what they wish to do and being fulfilled in carrying out what we as women can do. Thank you.